This video has been funded by an educational grant from Fresenius Kabi, Swiss BioSim GmbH.
We today capture only still a minority of osteoporotic patients who have already sustained a fragility fracture, and we know that without appropriate osteoporosis therapy, those patients will have a very high probability to refracture within a few years.
In this episode of our special series examining osteoporosis care, we speak with Professor Serge Ferrari from the University of Geneva about what is changing for patients and clinicians. The odds against those patients are steep. Of the 10% of older adults who experience a fragility fracture, 4 out of 5 go undiagnosed or untreated. Of that number, 1 in 5, or just under 2% of the overall elderly population, experience a new, worsening fracture within 3 years. Professor Ferrari walks us through the recent breakthroughs of osteoporosis research and how future investigations may have the most impact for patients.
So monoclonal antibodies for treatment of osteoporosis have appeared 15 years ago with denosumab, a monoclonal antibody against RANK ligand, as the first biological therapy for osteoporosis. Before that, we were using almost exclusively bisphosphonate, which we had for like 20 years, that were chemical compounds with anti-resorptive efficacy. And we had one anabolic, teriparatide, which was derived from our natural parathyroid hormone. So the upcoming and clinical development of denosumab really switched the world of osteoporosis into like biologics therapy. It was therefore the first time we were able to really directly target a pathophysiological pathway of the disease with an efficacy that was unprecedented, in that case, in terms of inhibiting bone resorption and blocking the effects of osteoclasts. And that was, of course, the first step, but it took about like 10 years before we got the second biologic with romosozumab, inhibitor of sclerostin, new anabolic agent. And then now we've seen other sort of biologics derived from hormones like abaloparatide coming for treatment.
How fast is that pace of research moving?
The development of the two major biologic agents we have now, denosumab on one side and romosozumab on the other, targeting two major biological pathways in bone and really addressing the biology of bone fragility, has been a major step forward. Now, that being said, those treatments have their limitations and drawbacks, and so the developments that are going on are in different directions, trying to, I would say, improve the efficacy and safety of osteoporosis therapy. Some developments aiming at molecules that are easier to administer, for example, going from subcutaneous treatments to oral treatments for bone anabolic drugs, not with greater potency, but perhaps with greater tolerability and facility to administer. Other treatments try to address some of the limitations of the current biologics, particularly the limited effects in time of romosozumab, trying to prolong that anabolic window. So I would say that what's really achievable in the next 3 to 5 years is more an improvement, I would say, of the known treatments we have and still targeting the same pathways, rather than completely novel molecules targeting different pathways.
How can biosimilars help close that therapeutic gap?
I don't believe that decrease in price will necessarily translate immediately into a larger number of patients treated, because at the end of the day, the proportion of patients with the disease that we treat depends on a lot of factors. The first being the identification of patients at risk of fractures, which still remains a huge, huge problem, considering that the essential diagnostic tool, which is bone mineral density, DEXA, is available broadly, at least in Switzerland and Europe, the reimbursement for the exam is not achieved for general population screening. So there is a vast majority of osteoporosis people who just don't know they have osteoporosis until they have a fracture. Then when they have a fracture, the orthopedic care is excellent, of course, but the translation of that fragility fracture into the concept of osteoporosis that requires therapy is not immediate. The development of fracture liaison services is there to identify those fractured patients who deserve osteoporosis therapy, but fracture liaison services are still limited. There are about 23 or 25 hospitals in Switzerland that have a recognized fracture liaison service. And then above and beyond that, there is the whole fears and perceptions about benefits and risks of osteoporosis therapy, which has discouraged some doctors and certainly a lot of patients to be treated because of this perception of some risk related to therapy.
How do you weigh that cost benefit analysis with adverse events like osteonecrosis or atypical fractures?
The risk of atypical femoral fractures or osteonecrosis of the jaw, even with very long-term exposure of denosumab, is really low. We have calculated from the Freedom Extension study that by the time we see one atypical femoral fracture with denosumab long-term, we have spared 280 fragility fractures. So the benefits risk ratio remains extremely good even with very long-term therapy. So that would not be my clinical concern. My clinical concern is rather to make sure that when I treat long-term, I achieve a bone density which is high enough. And when I say high enough, is not just above osteoporosis threshold at minus 2.5, but above that, above minus 2 T-scores, for example, so that if I want to stop that therapy or the patient wants to stop and I give a bisphosphonate for consolidation, we can afford to lose 3-4% BMD without a consequence for the patient. And then specifically for denosumab, obviously since many years now, the evidence that when stopping therapy, there is a rebound of bone turnover and an increased risk of vertebral fragility fractures, if not consolidated by bisphosphonates, has scared a lot of patients to go towards this biologic agent, no matter how efficient and well tolerated it is.
What are the open research questions of osteoporosis that you want to see resolved?
What needs to be further studied is perhaps the question of the dose with long-term therapy, and particularly if we want to stop therapy. There are some very small trials that have looked at tapering the dose before stopping completely, which may be an interesting strategy before giving bisphosphonates to minimize the post-denosumab bone loss, but we need to do better trials in that regard. The other aspect where there are more trials going on and we need more answers is with regard to sequential therapy between denosumab and osteoanabolics, and particularly the sequence of romosozumab to denosumab and denosumab to romosozumab. In other terms, when we have a patient on denosumab that, say, sustains a fracture nevertheless, and we think of providing anabolic therapy to that patient, whether teriparatide, abaloparatide, or romosozumab, we know it's not ideal to just switch them to this also anabolic, and perhaps combination therapies at that point or different strategies with a bisphosphonate in between could be better. Those are ongoing or soon to come trials that will help us in the long-term management of these patients.
What can be done to improve osteoporosis management?
Oh, I have two clear wishes here. The first would be to reinstore a systematic screening of osteoporosis in the population. I would say women after age 55, men after age 60, as part of the general healthcare assessment that we should perform to prevent the events of aging, like fragility fractures in this case. I hardly understand why there are programs for systematic screening of the risk of breast cancer through mammography or colonoscopy for cancer of the colon, and that an exam so easy to perform and so cheap as DEXA is not part of a global screening strategy for primary prevention. The second, as I mentioned before, is the continuous development of fracture liaison services in hospitals that treat that have trauma orthopedic surgery and treat fragility fractures, because again, we today capture only still a minority of osteoporotic patients who have already sustained a fragility fracture. And we know that without appropriate osteoporosis therapy, those patients will have a very high probability to refracture within a few years.
In summary, biological therapies have revolutionized the treatment of osteoporosis. Proper management of treatment sequences with these drugs and the role of bisphosphonates can still be improved and needs further study. Personalizing doses or tailored combinations of therapies could help with easing patients off biologics after long-term usage, with ongoing trials yet to report data. Fracture liaison services can reach those at risk, but their integration into broader health systems could be improved. Early screening and intervention remains the most cost-effective way to prevent future harms from fractures.